Good morning, respected faculties, my batchmates, and my juniors. My topic of presentation today is International Association for Study of Lung Cancer Staging. Lung cancer is the leading cause of cancer mortality. Accurate staging is crucial for prognosis, treatment planning, and research. IASLC refines the TNM system specifically for lung cancer. In TNM, T stands for primary tumor, N stands for regional lymph nodes, M stands for distant metastasis. And staging is based on the combination of these three parameters. The primary tumor, TX, primary tumor cannot be assessed. This includes tumors proven by the presence of malignant cells in sputum or bronchial washings, but not visualized by imaging or bronchoscopy. T0, no evidence of primary tumor. TIS is carcinoma in situ. T1 is tumor less than 3 cm in size, which is surrounded by lung or visceral pleura or in a lobar or more peripheral bronchus. It's subdivided into T1MI, which is minimally invasive adenocarcinoma, T1A, tumor size less than 1 cm in greatest dimension, T1B, tumor more than 1 cm but less than 2 cm in greatest dimension, T1C, tumor more than 2 cm but less than equal to 3 cm in greatest dimension. Then comes T2, which comprises of tumors between more than 3 cm and less than equal to 5 cm size. It is subdivided into T2A and T2B. T2A consists of tumor more than 3 cm but less than equal to 4 cm in greatest dimension, which invades visceral pleura or invades the adjacent lobe or mainstem bronchus, not involving the carina, or is associated with atelectasis or obstructive pneumonitis extending to the hilar region, involving either part of or the entire lung. And 2B comprises of tumor more than 4 cm but less than 5 cm in greatest dimension. T3 comprises of tumor between more than 5 cm to less than equal to 7 cm in greatest dimension, which invades parietal pleura or chest wall, invades the pericardium, phrenic nerve, azygous vein, or thoracic nerve roots or stellate ganglion, or it has separate tumor nodules in same lobe as the primary tumor. T4, when the size of tumor is more than 7 cm in greatest dimension, is stamped as T4. It involves tumors invading the mediastinum, thymus, trachea, carina, recurrent laryngeal nerve, vagus nerves, esophagus, or diaphragm, invading heart and great vessels, invading subclavian vessels, vertebral body, lamina, spinal canal, cervical nerve roots, or brachial plexus. It also involves the tumor, separate tumor nodules, which are there in different ipsilateral lobe rather than that of primary tumor. The regional lymph nodes, NX means there is no regional lymph node accessible. N0 is no regional lymph node metastasis. N1 is metastasis in ipsilateral peribronchial and or ipsilateral hilar and or ipsilateral intrapulmonary lymph nodes, including involvement by direct extension. N2 means metastasis in ipsilateral mediastinal and or all subcarinal lymph nodes. It is subdivided into N2A and N2B. N2A is single N2 station involvement, or N2B is multiple N2 station involvement. This is different from the previous edition of 8th edition of TNM staging, where N2 was not subdivided. But in this section of 9th edition, N2 is subdivided into N2A and N2B. N3 is metastasis in contralateral mediastinal, contralateral hilar, ipsilateral, or contralateral scalene or supraclavicular lymph nodes. Then comes distant metastasis. M0 is no distant metastasis. M1 is distant metastasis. M1 is again subdivided into 1A, 1B, 1C. 1A has tumors with pleural or pericardial nodules, malignant pleural or pericardial effusions, separate tumor nodules in contralateral lobe. 1B has single extrathoracic metastasis in single organ system, and 1C is multiple extrathoracic metastasis, which is subdivided in this edition in M1C1, which is multiple extrathoracic metastasis in single organ system, and M1C2, which is multiple extrathoracic mets in multiple organ system. This is again different from the 8th edition, which had no such subdivision of M1C group. Then IASLC also gives us the nodal staging. It comprises of station 1, which has lower cervical, supraclavicular, and sternal notch nodes. Station 2 is upper paratracheal right and left. Station 3 is prevascular retrotracheal. Station 4 is lower paratracheal right and left. Station 5 is subaortic. Station 6 is para-aortic. Station 7 is subcarinal. Station 8 paraesophageal. Station 9 pulmonary ligament. Station 10 to 14 is within the lung. That is 10 is hilar, 11 interlobar, 12 lobar, 13 segmental, 14 is subsegmental. This is the axial view of the CT scan for location of the nodes. And further are certain CT scan cuts which shows us the location of the mediastinal nodes. In this cut, we can see the sternal node and the prevascular node, station 3. Here we can see right and left paratracheal, prevascular and retrotracheal nodes. Here we see right and left lower paratracheal nodes, paraesophageal nodes. In this section, this is the same. In this section, we see the subaortic node as well. Section which shows subaortic node and the paraesophageal nodes. Then we have the subcarinal and the hilar lymph nodes. And this has pulmonary ligament nodes and the paraesophageal nodes again. The staging of lung cancer for non-small cell lung cancer is done as per stage 1, 2, 3, 4. And for small cell lung cancer, we just have two groups, limited stage and extensive stage. Limited stage is where the disease is confined to one hemithorax, the mediastinum and ipsilateral nodes. It defines a primary tumor and the regional nodes that can be incorporated into reasonably safe radiation port. An extensive stage includes patients with malignant pleural or pericardial effusions, contralateral, hilar or supraclavicular lymph nodes, and or distant metastasis. This is the entire staging system which is formed after combining the various T, N, and M parameters of the lung cancer. Prefix used in TNM classification, clinical TNM, which is based on imaging before treatment, which we do by analyzing the CT scan and X-ray reports. Then the pathological staging, which is done after surgery, post resection on the surgical specimen. There is restaging, which is used after after all the treatment has been done. It can be applied both in absence of resection or after resection as well, which is termed as YCTNM and YPTNM respectively. The TNM 9th edition suggests including an E prefix to indicate the type of evidence used for staging. That is, we are staging it based on imaging or pathology, etc. So E1 is based on physical exam and signs, E2 is based on imaging, E3 is based on tissue, that's cytology and histology, and E4 is based on the resection specimen. Example, CT2A, N2A, M0, E3A would indicate clinical staging with cytologic confirmation, since it's telling E3A, so it's cytologic confirmation of N status. PT1C, N0, M0, E4 means pathologic staging based on the surgical resection. The subsolid lung lesions are lung cancers with ground glass morphology, which represents lipidic growth, that is tumor cells proliferating along the surface of alveoli without invasive growth. Subsolid lesions may or may not exhibit an internal solid component, which is thought to represent the invasive portion of the tumor. For subsolid lung cancer, the radiology report should always mention both total lesion size and, if present, also solid component dimensions, as both are of importance. This should be obtained on contiguous thin slice CT reconstruction in lung window. The classification of subsolid lung cancers are into two parts, pure ground glass and ground glass with solid component. When the total size is less than 30 mm, subsolid lesions with pure ground glass morphology are classified based on greatest total lesion dimension, and that can at most be classified as in situ cancers. When the size exceeds 30 mm, the subsolid lesions are always at least CT1A regardless of pure ground glass or part solid morphology. In ground glass with solid component, if the internal solid component is present, the subsolid lesions are no longer classified based on the total lesion dimension, but on the greatest dimension of the solid component, which is presumed to be representing the invasive component seen on histopathology. There are different diagnostic modalities which are helpful in staging. Contrast enhanced CT scan, which is the backbone for T and nodal assessment. PET CT scan is the metabolic nodal assessment and detection of distant metastasis. Brain MRI, as we do mostly in cases of small cell lung cancer to detect CNS metastasis. EBUS TBNA, EUS FNA, which is the minimally invasive mediastinal node sampling method. Mediastinoscopy or wax biopsy is surgical nodal sampling when needed. Bone scan and abdominal CT scan or ultrasound is done as directed. Histology and cytology is always required for definitive management. The mediastinal staging procedures include transthoracic needle aspiration, transbronchial needle aspiration with or without EBUS, endoscopic ultrasound needle aspiration, mediastinoscopy, and thoracoscopy. This is a chart from Fishman which tells us which procedure which we can use for which lymph node station sampling. Like TBNA is used for station 4, 7, 10, EBUS TBNA is for 2, 4, 7, 10. EUS FNA is used for station 5 and 7 to 9. CT guided transthoracic needle aspiration is used for station 3, 5, 6. Mediastinoscopy majorly for 2R, 2L, 3, 4R, 4L, and subcarinal. Thoracoscopy is for station 4, 7, 8, 9, 10. Mediastinoscopy is cervical mediastinoscopy is used for taking biopsies from stations 2R, 2L, 4R, 4L, and 7. Station 1 nodes are located above the suprasternal notch and are not routinely accessible by this method. In left upper lobe, tumors may metastasize to subaortic lymph node station, that is station 5, and paraortic nodes, that is station 6. These cannot be biopsied through routine cervical mediastinoscopy. So extended mediastinoscopy is an alternative for anterior second interspace mediastinostomy, which is more commonly used for exploration of mediastinal nodal stations. It is far less easy and therefore less routinely performed than conventional mediastinoscopy. Then we have endoscopic ultrasound guided FNA, which can be performed of all mediastinal nodes that can be accessed from the esophagus. In addition to the mediastinal nodes, it also accesses the left adrenal gland, the left lobe of liver. It particularly provides access to nodes in the lower mediastinum, station 7, 8, 9. So this is the comparison table between the 8th and 9th edition. The main differences are in the describing the nodes and metastasis, which then upgrades or downgrades certain stages of the tumor. In T descriptor, there is no change in 9th edition. There is an N descriptor, as mentioned earlier. N2 was subdivided into N2A and N2B. M descriptor, M1C was subdivided into M1C1 and M1C2. Hence, the stage grouping has also changed because of these new divisions, which the cancer, which was initially stage 2B, that is T1 and 1, is now stage 2A. T2 and 2, which was 3A, is now 2B. T2 and 2, which was 3A, is now 3B. The staging also adds E prefix, as mentioned earlier. So depending on these staging integration, it helps us in guiding the management. Like early stage tumors, stage 1 to 2, are planned for surgery plus minus adjuvant therapy, which can be radiation, which can be chemotherapy, or can be both. It's locally advanced cancer, stage 3, which has multimodality approach, and metastatic disease have systemic or targeted or immunotherapy approach. So accurate TNM staging is the cornerstone of the lung cancer management, which defines prognosis, guides therapy, and ensures standardized global reporting. The 9th edition refines staging with greater precision, especially for the subsolid lesions, nodal stratification, and metastatic burden. The radiologic pathologic correlation and multidisciplinary evaluation are vital for correct stage assignment.